Thank you very much for the invitation, and good morning, everyone. Okay, so I have no financial disclosures. So what I have here is, on the left, the coronary circulation without, and on the right, with microvessels. This looks a lot like the fibrous roots of rice plants. And these microvessels are so densely packed together because they need to be able to reach every cell in the body to provide nutrients and oxygen, to remove waste, and overall to maintain our systemic blood pressure. You can see clearly why maintaining healthy microvessels is vital to the health of the entire organism. But just like every other tissue in the body, blood vessels can become diseased. And when we think about disease vessels, normally we think about obstruction from atherosclerotic plaque in large arteries. However, this is not the case with microvessels. With microvessels, dysfunction manifests in the form of dilation and constriction that is abnormally regulated. And there are a number of causes to microvascular dysfunction, which I will refer to as MVD going forward. There can be structural changes, such as narrowing of the lumen, as you could see on the bottom diagram, and or thickening of the perivascular smooth muscle layer. There can also be rarefaction of capillaries, meaning loss of capillaries. But sometimes you can also get functional changes in the absence of overt structural changes. For example, the inner endothelium lining the lumen can become dysfunctional in that they are compromised perhaps in the way they release vasoactive dilating factors, such as nitric oxide. At the same time, the smooth muscle layers could also abnormally regulate arteriolar tone. So microvascular dysfunction, we know, is consistently associated with these three comorbidities that afflict a lot of people globally: hypertension, obesity, and diabetes. Now, at the same time, these comorbidities are also associated with heart failure. So the question is, how is heart failure associated with microvascular dysfunction? Are they correlative? Do they arise? Are they the fallout from the same stressors in the body? Or is one a causative factor for the other? In order to answer this question, we need to turn to animal models where we can actually reproduce microvascular dysfunction. And what we currently know is that MVD is believed to present early in heart disease, including heart failure. And with this early presentation, this can potentially provide us a window for early detection of disease, and as a result, the possibility for early and timely intervention. But going back to the question of how is MVD related to the progression of heart disease, animal models can help us understand the relationship between the two. But in order to do this really well, what we need are models that, quote unquote, try to naturally, as natural as possible, naturally mimic the temporal evolution of MVD. So let us look at what animal models are at our disposal. There are obviously a lot of surgical methods, but these are not relevant when it comes to modeling microvascular dysfunction. We also have models that look at hypertension, try to mimic hypertension, and models that mimic metabolic syndromes such as diabetes and obesity. And on the top row, I have all the non-genetic models, some of these, okay, and some of the non-genetic models. And the bottom row, I have genetic models. Now, from my view, my perspective, genetic models are really excellent and very valuable when you want to look at pathways and when you want to do targeted intervention. However, these genetic models tend to give rise to a lot of late-stage symptoms all at once, very, very early on. For example, in the DB model of type 2 diabetes, it's been shown in the literature that you can actually see changes on strain imaging and also microvascular rarefaction early on. And for this reason, genetic models are also not the best for looking at microvascular dysfunction. Okay. Now, what I have on the right, upper right, are these metabolic models that involve diets. And when you look at the literature, you'll find that there are a lot of different diets people have tried, and there's some inconsistency in the results. For example, if you look at the high-fat diet alone has been shown to induce endothelial dysfunction. But there has also been contradictory reports where high fat alone doesn't do anything to the endothelium in the absence of high sucrose. What has been consistently reported, however, is the addition of high sugar does give you the phenotype that you want. And so we will go forward with this model, the high-fat, high-sucrose diet. So what I'm going to show you over the next few slides are highlights from a 2-year-long study done in male and female Sprague-Dawley rats who were given a high sucrose diet, about 20% sugar, high fat, about 21% fat. And we applied a battery of different analysis, imaging tests. One of the most interesting results that we observed was on treadmill tolerance, exercise tolerance. And you could see that as early as 5 months post-diabetes, we can already see a significant reduction in exercise tolerance in both diabetic male rats and diabetic female rats. Okay. On echocardiography, we saw a slightly lower ejection fraction that still remained normal, so this is indicative of a preserved ejection fraction. The left ventricular volume was slightly increased, and there was a delay in the relaxation. And notably, we saw no changes on strain imaging throughout that 1-year study in either sex. But this clearly points to a diabetic cardiomyopathy phenotype. Now, the question that we asked ourselves was, why are these animals not able to exercise at such an early time point before echo evidences emerged? And so we also looked at photoacoustic imaging data. Photoacoustics is a technique that looks at perfusion of the microvasculature. And you could see that as early as 4 months, there's already a reduced, even though insignificant, reduction in the leg muscle perfusion of male diabetics. No changes in females. By the time we reach 10 months post-diabetes, there's a significant reduction in perfusion in the leg of both male and female diabetic rats, as you can also see in the images at the bottom of the slide. Okay. So to understand why we're getting these reductions in perfusion, we also did histopathology and immunohistochemistry, and one of the first findings was we had no loss of microvessels. There was no rarefaction in either the heart or the leg in either sex. But histopathology revealed that we did have thickening of the perivascular smooth muscle layer in the leg muscle, and I'm going to show you those results right now. So when we look at the myocardium, myocardium had no rarefaction, and it also had no hypertrophy of the vascular smooth muscle layer. So what I have here, now I don't have it labeled very well, but when you look at the bar graph going from left to right, I'm showing you male control, male diabetic, female control, female diabetic. No significant difference in terms of the ratio of smooth muscle surface area relative to the endothelial surface area. When we move on to the leg muscle, we start to see a significant difference. Now, these were all done at the month 10 or 12 time point at the end of the study. And you could see in the male, the two bars on the left, there's no significant increase in the thickening of the smooth muscle layer, but there's a substantial thickening in the female diabetic leg. Okay? And these are all, this analysis was done on microvessels between 10 to 25 microns in diameter, so the small vessels. What we did see in the male diabetic cohort, however, was that when we look at the larger blood vessels, ones that were in the 25 to 100 microns range, we saw thickened vessel wall in diabetic male rats only, and this did not appear in our female diabetics, again pointing to a sex-related difference that is consistent with what we know of, microvascular disease associated with men versus female. So to summarize our findings from this study, we had no rarefaction in either the heart or the leg muscle. We had no vascular smooth muscle thickening in the heart, but we did have smooth muscle thickening in the vasculature of the leg, presenting in the microvessels in females and macrovascular level in male diabetics. Now, when we think back on this study, a lot of these the smooth muscle thickening, we call them vascular, okay, let me just, I'm at a loss here. This term, just want to make sure that I get this right. This vascular remodeling that we're seeing structurally, we observe at month 10 to 12, okay? But recall that we were able to see a reduction in perfusion as early as month 4 to 5 in the diabetic males. So the next question that we're pursuing right now is it possible for us to detect these microvascular dysfunction earlier, okay? And what we've been trying to do in the past half a year to 1 year is use a new MRI technique to quantify microvascular dysfunction in a way that is very different from perfusion imaging using photoacoustics. So with this method that I've dubbed blood pool steady state MR imaging, what we're looking at are changes in blood volume due to vasoreactivity, and this method is not influenced by confounding factors from changes in blood velocity, blood flow rates. So you could see here in this pilot study done on the rat kidney 5 years ago, with this method you can visually see the signal intensity decrease in the renal cortex, indicated by that triangular arrow, and then come back up, indicating vasodilation as we go through different levels of hypercapnia. Okay. Now, taking this same technique to the current study that's being led by my PhD student, Sadi Lawai, he's been able to show, and this is still very preliminary, he's been able to show that within the first 2 months after the onset of diabetes, female control animals are exhibiting a slight vasodilatory response in the septum. So you could see in the third panel there. And this is a cross-sectional image of the heart, a T1 mapping on MRI. But when you compare it to the female diabetic, there's a blunted vasodilatory response, and we're seeing this as early as 2 months. So the study is ongoing. It will be about springtime of 2023 before the study concludes, but there are already some interesting observations we can make. In the cardiac system, female rats are exhibiting a blunted vasodilatory response, and in the leg, these same female rats are exhibiting blunted vasoconstriction. So vasoconstriction is a parameter that is not often looked at, but I feel is still very important when you want to look at the full spectrum of how healthy the microvessels are. Now, what about other models of heart failure? Because we weren't able to get hypertension actually until month 10 and 12 in our natural, quote unquote, natural model, my other PhD student started to look at a 2-hit model published in 2021. And in this model, the chemical L-name, which is a NOS inhibitor, was applied to induce hypertension deliberately. Now, with this 2021 paper, the authors were able to show that all the phenotypes of HFpEF emerged, including rarefaction, but Aaron Troy was not able to get this phenotype. We did not see any microvascular rarefaction in either sex, and instead of a reduced coronary flow reserve, we actually had an elevation at stress compared to rest, okay? And so I'm showing you this results just to highlight one difficulty that we encounter when we work with animal models, and that is, it's not all models are reproducible, and one possible reason why this model didn't work for us was that it did not have high sucrose in the high-fat diet. So what are the lessons that we can learn from the work we've done so far? First of all, you do need high-fat, high sucrose to recapitulate MVD. Hypertension manifests after structural changes occur in your vasculature, and inducing hypertension doesn't necessarily give you rarefaction. Furthermore, because we didn't see rarefaction, this is a good indication that it's a very late phenotype. And to end with this slide, how can animal models provide new insights into heart failure? I personally believe that we need to use non-genetic models in animals with a long lifespan, long enough so that we can actually allow the heart failure to develop. And this is really important. I just want to emphasize this. We need a model that allows us to temporally separate MVD from all the other heart failure symptoms, because if we can do so, we can answer the question, how early does MVD actually emerge? And if it does emerge early enough, can we target MVD and see if treating MVD can steer the course away from a trajectory towards heart failure. And that would help us answer the question, is MVD and heart failure correlatively related or causative? And finally, we always need a platform in order to study MVD. We'll need a non-invasive platform to be able to detect the disease, and we also need to be able to do this in a tissue and organ-specific manner, as you'll hear more about from the next speaker. So with that, I'd like to thank my collaborators on this project, my students over there at that table, and particularly I want to give a shout out to Erin and Sadi, who provided me with the figures for this presentation.